Today's episode is brought to you by Flash Media Studios. Also, don't forget to subscribe on YouTube and Spotify. And exciting news, make sure you are a Patreon member. We have amazing content pushed out.
We have a really special episode for you today. Today, we sit down with Dr. Jordan Perlow, who is a maternal-fetal medicine doctor, and we talk to him about everything you could possibly want to know if you are ever diagnosed with a high-risk pregnancy, if you are ever diagnosed with birth defects, fetal anomalies. We get into all of it, everything from shoulder dystocia to VSDs to vasoprevia, and we really get into the science behind it. It's a really cool episode. We're so excited for you guys to listen. Without further ado, here is Dr. Perlow. Okay, we are so excited to talk to you. And I think I mentioned it to you before, but majority of our audience is women. A lot are moms or women trying to get pregnant. And I always think, when I went into my pregnancy is that you're like, yep, everything's going to go according to plan. And you just hit these milestones, bada bing, bada boom. And then the baby comes. And there is this whole conversation about high risk pregnancies that I don't think you know until you've been there. And we're going to get into it because we've both experienced high risk pregnancies. And I don't want this conversation in any way to be scary to moms, but I do think this is something that women should know about. And I want it to be informative and supportive. So I guess let's just start with the basics of what is a high risk pregnancy?
Yeah, that's an excellent question. And it's oftentimes asked because it does kind of conjure up this sense of a fright, to be told you have a high-risk pregnancy. But high-risk pregnancy means a lot of different things. And maybe we need to somehow soften that terminology.
Right.
And provide language that is reassuring to a woman rather than something that creates anxiety, because we know that anxiety is not helpful or conducive
That's right. Yeah.
to a healthy pregnancy. But to answer the question, I think what we want to talk about are situations that exist or develop where it creates a situation where the outcome of the pregnancy is potentially at higher risk of adverse outcome. And when you talk to physicians, you go to medical meetings and such, you hear this term adverse outcomes. What does that mean? It means the end of the pregnancy resulting in some situation that might have been better had that high risk feature of the pregnancy not been present.
Right.
So, for example, there's such a spectrum of the things that might define a pregnancy as high risk. For example, if a woman is age 35, which is a very common thing
right
nowadays, 2 of them.
in the current society that we live in, and has been for some time now, that's a situation where we know statistically that essentially every potential complication of pregnancy is higher. What I explain to my patients is that we want our patients to be fully informed, because the information allows that individual to really feel self-empowered in the understanding of their own health and what those potential risk issues might be.
Right.
But what I explain is that in general, pregnancy risks are relatively low. So even statistically, when we say the risk is twice as great as it would be if you had been younger,
Takes it up to 2%
we're
instead
going
of 1%.
down, we're going up, quote
Yeah.
unquote, from a very low risk to something somewhat greater.
Right.
But when we look at it and analyze that statistically, it is significant. So the goal is to identify those risk issues that might adversely impact the outcome of the pregnancy and to put into place a care plan that takes into account those things so that what we do is we achieve the very best pregnancy outcome possible given the clinical circumstance that we find ourselves in.
Yeah.
So on the one end of that spectrum, a woman's 35, she's perfectly healthy in all other respects. And on the other side of that spectrum, let's say we have a woman with quadruplets that has diabetes and had 3 previous C-sections
Ugh.
and has other, health issues, and maybe she's obese and other sorts of things, or women who've had heart transplants. I've cared for several such
Wow.
such women in the past, kidney transplants, liver transplants, heart lung transplants. So, that's a whole different
Yeah, the spectrum is
conversation.
wide for high
It's
risk.
it's almost limitless.
Right.
Yeah.
So,
You've probably seen a lot in your days.
so when you use the term high risk, it's like, well, what do you really mean by that? And
Right.
that was the point of your
So
question.
and taking out the woman, what fetal factors automatically put a pregnancy into high risk? Like,
Well, there's a number of different things. Certainly, if a baby isn't growing, that would be one such example. And usually, maternal risk issues potentially predict the fetal
That's
complications.
interesting.
See, so for example, a woman who's older is at risk for complications such as what we just mentioned
mhm.
about fetal growth, but also at higher risk for diabetes and at higher risk for having a baby with birth defects, at higher risk for genetic complications of the baby. But again, we're talking statistically significant, greater likelihoods, but still not an overwhelming
Right.
situation where it's more likely than not that those adverse things are going to happen.
Well, and even like IVF, you're considered high risk, correct?
IVF, a pregnancy that's achieved through IVF and even other assisted reproductive
Even an
technologies,
IUI.
yeah, those pregnancies are, again, when we look at the literature and we study the outcomes of those pregnancies versus naturally conceived pregnancies, there's no question that essentially all the risks are higher
Yeah.
in those pregnancies.
Right.
And so, again, that's not to frighten women
Yeah.
that are pursuing assisted reproductive technologies, but just to say that once that pregnancy is achieved, to make sure that the care plan takes into account the fact that there are those risks
There's factors.
present.
I conceived both of my children through IVF. And I remember when they said, okay, well, now you're high risk and you need to go to a high risk doctor. I'm like, I was already so worried about getting pregnant, staying
Right,
pregnant. And now you've
right.
told me that I am high risk and I'm going to, and I think AMA, advanced maternal, it was that, or no, that's
Right.
AMA is you're above 35. What is MFM? Is that,
Maternal-fetal medicine, that's
yes,
me.
that's you.
Yeah,
So I was going to an MFM and I'm like, oh my gosh, the
right.
anxiety and the stress now that I've had is out the roof now.
Well, we know that in pregnancies conceived through IVF, the risk for birth defects is higher. So it's a very important component of care that ultrasound be utilized in a facility that has expertise in detecting fetal birth defects, or anomalies, as we call them, um, at different stages of the development of the baby. So, for example, just the typical anatomy ultrasound is around 18 weeks or so. And then, because we know that the fetal heart is most commonly affected in terms of developing birth defects, there's a special ultrasound that's done of the baby's heart
Mhm.
that's done typically around 20 to 22 weeks, closer to 22 weeks, when the heart reaches a size where we have the ability to detect those abnormalities. And detecting those things ahead of time makes sense for obvious reasons, I think, to know what to anticipate at the time of delivery. So we have the appropriate consultants already aware of
Right.
the care that the baby might need, potentially right from the moment of delivery.
But you are only getting that additional heart ultrasound if you are seeing a maternal fetal medicine doctor, correct? Like you're not getting that
Well,
if you're
Or if
normal
there's another screening
pregnancy.
you're getting that special ultrasound if there's a risk
Right.
for congenital birth defects of the heart. So, for example, we mentioned IVF pregnancies, but another example would be a woman who has heart disease in the family,
Mm.
where there's a family history that imparts an increased risk to the pregnancy, and also women with diabetes. And this is worth, if I can spend a minute about this, because it really is a public health situation where women with diabetes, they may think, well, I guess I need to get pregnancy care very early, so they make the efforts and such. But what really matters in addition to that, is making sure that their blood sugars are well controlled before they even conceive.
Mm.
Because we know if the blood sugars are high around the time of conception, then there's increased risk for birth defects of the heart, of the brain, of the spinal cord, of all the structures of the baby. So, one of the key elements of preconception counseling is to identify women who have these risks for adverse pregnancy outcomes and to talk with them about ways that they can improve the chances of everything going well, even though they're high risk, as we've defined it
Mhm.
earlier.
Yeah, so come way before you get pregnant.
Right. So, people think, well, I'll get in and get my prenatal care early and I'll get my prenatal vitamins and everything will be, just great. But when it comes to diabetes, really getting the blood sugars under control, and there's different blood tests that can be done to make sure that we're in good control so that when the pregnancy does occur, the chances are that that
Lower.
baby won't be at any greater risk for developing birth defects.
So both my children, like I said, were conceived during IVF. And with my first pregnancy, I was told at 22 weeks, okay, go for the 2 hour ultrasound. And it was 2021. So it was COVID times. And I brought my mom with me because I'm like, she didn't get to see any of the other ultrasounds I want her to see. And, it's a
Right,
long
right,
ultrasound for them to check all the
right.
chambers and the valves. And you're
Exactly.
sitting there like, okay. And they said heart looks great. And I was more about for my mom to see the baby, to be honest. I was like, I know the
Sure.
heart's fine. But then they said, did anyone talk to you about your placenta? I said, yeah, I think it's anterior and it's out of the way and it looks good. They're like, okay, well, the doctor's going to come in. I'm like, well, that's never good.
Hmm.
The doctor came in and he said, you have vasoprevia. And I'm like,
Ooh.
I'm sorry,
Yeah.
who?
Yeah.
What? And I'm Googling on my phone, which is, the scariest thing that
Wow.
all of this information is right there in the palm of your hand that you could find all this out. But they had missed it in every ultrasound, my anatomy scan, every single ultrasound that I'd had, and being high risk, being in IVF, all of you would think, I think maybe every 2 weeks I was having an ultrasound, missed until my 24-week appointment. And
Hmm.
if I didn't have that appointment, you could probably speak to the outcome of my pregnancy with a versus C-section versus a natural labor, but I always think my MFM because if I did not have that extra screening, my son probably would not have made it here because your blood supply, the baby's blood supply is over the cervix, almost like a hammock, right?
Right. Well, it's a situation that you mentioned, vasoprevia, that's it's relatively rare, but not that rare. So it's something that is worth conversation to make others aware of, especially if a woman's been diagnosed with a placenta previa early in the pregnancy, where the placenta is covering the
Mhm.
cervix. Many of those placenta previa situations will resolve, and the placenta will move out of the way, but we published a paper some years ago that actually showed that even with a resolved previa, it leaves a very high risk for vasoprevia. And that's where maybe the placenta has moved away, but one of the blood vessels running between the baby and the placenta is running freely
Mhm.
in front of the cervix. And that is a potentially life-threatening risk issue for the fetus, because if the water bag ruptures, it can tear through that vessel. Or if the doctor goes to rupture the membranes
Right.
during labor, there's no way just from exam that you would know that there's vasoprevia. They could rupture the membranes and suddenly the baby exsanguinates,
Like
essentially.
the baby's blood supply is cut off immediately.
And the baby's blood volume is not so great. So in a very short period of time, all the blood in the baby's circulation is lost.
Yeah.
So, vasoprevia is something that is very, very serious and should be looked for during ultrasound, as was done in your
Yeah.
situation. And there's discussion about making that a routine part of mid trimester screening to evaluate for that. There are certain elements of looking at the umbilical cord and where it attaches to the baby and where it attaches to the placenta, but looking with color flow Doppler,
Mhm.
where we use the ultrasound and put the color on, you can see that blood vessel running right
When
in
you say
front
that,
of
it
the.
all comes back like it was
Yeah.
yesterday. Yep.
Now, I trained in OBGYN. My residency was during the 1980s. before we had any of that. So I grew up, so to speak, in a time period where vasoprevia was something that was not prenatally diagnosed.
And it's just a bad outcome.
It was just a bad outcome.
Yeah.
And I still, to this day, I can remember specific cases where that did occur.
Yeah.
And to see the progress over time, where the use of ultrasound and color Doppler technology, there's definitely, undoubtedly, there are babies alive today
Because
because of
of that.
that.
Oh, absolutely.
Because
My son is one, and I don't want to sound dramatic, but I will never forget her name. Her name was Haley, and she did my ultrasound. And if she didn't catch that,
yeah,
then my son probably would not have been here.
yeah,
And she
yeah,
did my daughter's ultrasound later, and I saw it and I started crying, hugging her, because I don't know if I don't know if people in medicine understand the weight of what they carry and hold for a mother. Like that, if that moment didn't happen, she checked the heart. The heart was good. Then she went to the placenta. She's like, I'm going to check everything else. And then she checked over my cervix, but she was there to check the heart. And I'm sure, as an MFM, like you really do your due diligence. It's a very long ultrasound. But
yeah.
I went through so many before that were not, it was never caught. So if that I hadn't been in that appointment in that room with that tech and her finding that, I would have had a scary outcome. And I was
Yeah.
hospitalized at 30 weeks and we took him at 34 weeks via C-section. And I kept thinking, oh my gosh, why this, why that? But hearing you say that, it's like such a good reminder of like, thank God we caught it when we did. And thank God we took the steps that we did to get him here.
Yeah, absolutely.
It's very dramatic.
Yeah,
Sorry to scare anyone.
But
Well,
it
and
is
I
a
don't,
serious thing, and
yeah.
she's talked about it before on the podcast, but it's nice to hear a medical professional
Yeah.
like really explain how serious it is. I'm curious, when you said about the screening, like what screenings do you think we should be doing in regular pregnancies, not just high risk pregnancies, to identify if there are any fetal, issues, or if there's, because for me, I wasn't diagnosed as a high risk pregnancy with my first until after my anatomy scan. So I'd just be curious to know what screenings you think are necessary or we should be implementing.
yeah. I think typically what's recommended, of course, is to do an anatomy ultrasound in the mid trimester, and then it depends really on individualizing the care as to whether follow-up ultrasounds are required
Right.
based on potential risks of a baby whose growth might be accelerated or restricted,
Mm-hmm.
depending upon the medical situation. If there's a greater risk of birth defects of the heart, then, as we were talking about, the follow up ultrasound, at 18 weeks, when we do the anatomy ultrasound, we can see a great deal of the baby's heart, but not in its entirety. The heart is about the size of a dime
Oh my
at
God.
18 weeks.
Tiny.
So when we look at that massive screen, when a woman's having her ultrasound, looking up at what's projecting up there, you're looking at the heartbeat, and it looks, so
Big
large,
and grand. Yeah.
but the heart's about the size of a dime, and
Wow.
we get to about the size of a quarter by 22 weeks or so, and so you can see a lot more of the detail. So
Yes.
that's potentially something, depending upon the situation, in terms of pre-existing or problems that develop, such as diabetes, that might be detected during the ultrasound or
Interesting.
during that pregnancy. But where things are heading, because certainly we want to detect, complications before the delivery, especially as it relates to birth defects.
Mm.
The earlier we can detect those things, the better. And so there are now specialized centers that are doing anatomy ultrasounds as early as between 12 and 14 weeks.
Wow.
Wow.
So this is kind of a new development where people are developing the skills to understand what constitutes abnormal anatomy at a time where just, a few years ago, we looked at ultrasounds during that time period primarily just to see, is the heart beating,
Right.
measuring the length of the embryo to
Mhm.
help with the dating of the pregnancy. And now we're talking about doing
Wild.
first trimester anatomical survey ultrasounds. And I think with the skills that are developing in specialized centers to do that, certainly in a patient who's at high risk for birth defects for whatever, the risk factor might be, seeking out specialized centers, typically university medical centers that have specialists in maternal fetal medicine with those capabilities. It's certainly an advantage because the earlier one makes those diagnoses, the earlier the woman and her family have the opportunities to make decisions
Mm-hmm.
as it relates to the continuation or not continuing a pregnancy,
Depending on
depending what the specific issues might be.
That
Well,
is so interesting.
are there any things that I mean, I feel like I'm making this up in my head or I've dreamt it, but aren't there certain surgeries that a doctor can do on a baby in utero?
There are,
I feel like
um,
it's like I'm talking about in the future, but I'm like, I feel like I've also heard
yeah,
stories of this.
and I've participated in some of those things in the course of my career, um, and we're learning that a lot of the things that we thought were helpful in the past may not be. Um, so that's kind of humbling to have done
Mm,
some of these things, but that's the nature of medicine.
medicine,
That
sure.
over time you learn more and more experience is gathered, more studies are done, uh, better powered studies are done
Mm-hmm.
that allow us to more definitively answer a clinical question. But for example, there are birth defects that are demonstrated on ultrasound with an obstruction of the outflow of urine from the baby.
Mm.
And we used to put shunts in the bladder, shunts in the kidney, um,
In the
in
babies,
the fetus.
in the
So we would
fetus. Wow.
have the mother in the operating room use ultrasound to evaluate where's the placenta, where's the baby, where's the umbilical cord, where's the area of interest that we need to do some intervention. And we would insert instruments into through the mother's abdomen and guide that into the fetus, for example, to the bladder,
Mm-hmm.
and place a catheter in the bladder that would drain from in the fetus's bladder to the amniotic fluid,
Yeah.
and then remove that from the mother. And
Because if without doing that, what would have been the harm to the baby if
uh,
that was not
lethal,
lethal?
Wow.
Okay.
because something that's not very well known in the general circles, I think, in discussions about birth defects and such, is that the baby's urinary system needs to be normal for the lungs to develop properly. And
Mm.
you might say,
How are
what's
those two connected? Yeah.
what's the connection there? And a baby needs a normal amount of fluid in the amniotic sac because at different stages of lung development, the baby is actually inhaling this amniotic fluid, which is essentially fetal urine. Okay. And that inflow and egress of the fluid is important for the normal development of the fetal lungs.
Wow.
So, babies that have abnormalities that reduce significantly the amount of amniotic fluid might survive through pregnancy, but be born and not have lung development sufficient to sustain life.
Wow.
You know what?
I
It really makes you stop and think it is a miracle, right?
No, it really is a
It
miracle.
it's absolutely a miracle. I'm glad you said that because you think of two microscopic cells
Wild.
that somehow find one another within
The
the
body.
fallopian
Yeah.
tube of the woman
Or a petri dish.
or a petri dish, and we get
And
human
more.
beings out of that,
It's
like the three of
Wild.
wild.
us
Mind
and
blowing.
billions of others. And it is really, and that's something that in the course of my, decades long career now, that I've come to appreciate just how miraculous it is when everything goes well,
Right.
because so many things can happen along the way. And that's why it's so important to empower women and with knowledge and understanding about these issues during
Totally.
pregnancy.
Well, and I think for us, being able to have this conversation about high risk pregnancies is a lot easier having gone through it. But I think one of the bigger parts, at least for me, so at my anatomy scan, my son, my first, he was diagnosed with a VSD. And I remember hearing it, and I didn't even know what she meant, and she
Hmm.
explained it to me very quickly, and I feel like there's this emotional component when you go into, like, I was not a high I think I was 31 when I was pregnant. I was healthy, like, we did the genetic testing, we
Yeah.
passed everything
Yeah.
else, and then hearing this, like, the delivery wasn't great at that moment, and I just started to cry, and she walked out the door, and I don't think my OB at the time knew how to tell me the situation, and she ended up coming back in and realizing that she dropped me with some heavy news. But there is an emotional component to what you do and
Oh
how
gosh,
you
yeah.
have to guide women through this. So, like, how are you helping women with the emotional side? Because I think I felt like it was my fault. I'm like, it's my fault that my son has the hole in his heart, and now is he going to have heart surgery and like all these things because I didn't. I still didn't know what I did or how, or it ended up closing, thank goodness.
Yeah.
But we
Yeah.
went through the rest of our pregnancy as a high risk pregnancy, and I
And they
was like,
usually do close,
and that's what,
typically.
when I went to go see a maternal fetal medicine doctor, that's what they told me. But it was like, it's a lot emotionally to understand that now you're high risk, and like, what do you do? And is it your fault? So, how do you guide women on the emotional side of things?
Yeah, I think it's of course always about communication and how you conduct a conversation, how you carry yourself through that and in communicating. Um, and I think it requires time. You can't do that quickly. You can't connect with somebody in a situation where they are getting news that's completely unexpected,
Mhm.
and somehow just present the black and white of the issue,
Right.
well, we'll see you in a couple of weeks, or we're going to
Rushed,
send
yeah.
you there, or we're
Yeah.
going to we'll look at it again in a month, or whatever it might be. um, it really takes some time to, and I think what you said is perfect, and that is that the immediate reaction is, well, I must have done something wrong. um, from the patient's perspective,
Right.
the woman saying, well, what did I do to cause this? And because in our day-to-day lives, um, we ask that all the time,
Mhm.
and it's usually true. We make decisions on all kinds of things each and every day that take us to one point or to another point,
Mhm.
and it's because of what we did or didn't do.
Right.
In the case of human biology and fetal development and all of the complexities of that, it's kind of a reboot to understand that this isn't something that a woman has control over, whether there's a VSD or whether there isn't a VSD, or whether there's other abnormalities and
Mhm.
such. So I think it's providing that sort of support, and sharing, not kind of covering over realities,
Mhm.
but making sure that a woman understands that this isn't something that she had control over, and putting forward the positive things that we've identified this early. We have wonderful people that specialize in whatever that specific
Mhm.
problem might be, and make sure we utilize all the resources that are available to us and set up those consultations and continue to follow through. So I think it's lots of conversation,
Yeah.
support, creating the best care environment for whatever that problem might be. And that provides the confidence for that woman that she's in the right place, that she's making good decisions for herself.
Well, you say that very nice, but I know that it's also probably a crazy amount of weight that you're carrying on your shoulders. And especially when you're going in with a family and you're trying to keep hope alive, but you're also trying to be realistic. How do you have a conversation, or how do you carry the weight knowing that the outcome will probably not be favorable for this family? How do you carry that?
It evolves, I think, over time. When you're a trainee and you're just starting to see these things. I mean, one day you're in college, the next day you're in med school, and now you're at the bedside of a woman who's about to deliver a baby at 22 weeks, and you know that there's no hope for survival. And then you do that hundreds of times over the course of many, many years. I think you grow in your ability as a physician or as a nurse to be able to support and communicate um, your care and your empathy with a patient under difficult circumstances. So I don't know if I can necessarily share specific words
Mm-hmm.
that describe how I have those conversations, but I can tell you that they're heartfelt, and you don't put up a wall. I don't think good physicians put up a wall to somehow protect their ability to carry on
Mhm.
with the other things in their lives. This is part of my life,
Right.
and that's how I see it, and it shapes who I am as a person in going about the day-to-day things in my life.
Mm-hmm.
Um, so it makes me appreciate things more, I think, and of course, even in my own life, as we were mentioning before, I've seen complications in pregnancy. So I think all of that just kind of goes into shaping not just myself, but the providers that I know who've been at it for a while,
Yeah.
and they grow in the work that they do. And like anything else, the more experience you have, the better you tend to be at what you're doing. I was very fortunate to have the most incredible mentors, and they were expert in this, in communication with patients.
Yeah.
I trained not with professors who stood in front of a classroom. I was with bedside teachers, and right here, very close by to where we are
Mm-hmm.
Oh.
right now at Long Beach Memorial and UC Irvine, in Orange at the hospital there, where I received my training from the world's best.
Yeah.
Yeah.
Well, it's such a big part of, what you do. And obviously today we're not going to be able to get into all of the birth defects that there are, but one that we talked about that I kind of want to get into before we started rolling was this shoulder dystocia. And I think
Hmm.
is that something that you can know ahead of time? Like we talked about the VSD and the vasa previa, like that you would know before you go into labor. For that, is that something that a woman, or it's literally as the baby is exiting, right?
Well, the diagnosis is only made when it happens.
Okay.
So it's not like
So
it's a defect, it's a complication during birth.
that's exactly right. It's
Okay.
a complication in the course of childbirth that's defined in various ways, but generally speaking, it occurs when one goes about to deliver the baby after the head is delivered, and the usual forces necessary to deliver the shoulder of the baby, because the shoulder is back behind the pubic bone at this point and has to come under the pubic bone in order for the rest of the baby to come out. And when one encounters resistance to that, that would be defined as a shoulder dystocia. So the good news is that there are many maneuvers that have been developed that allow for the resolution of a shoulder dystocia. Um, Most of the time, they are successful with just one or two. Sometimes it requires very invasive type
Mhm.
maneuvers where the obstetrician has to place his or her hand all the way up into the uterus and turn the baby 180
Ah.
degrees, or bring one arm out to create more room for the shoulder to come down. Um, and the potential for injury to the baby is very high under those circumstances. And during the time until the baby is completely delivered, the baby's not getting the degree of oxygen that it was getting prior to the baby's head being born. So the baby's not breathing yet. And the umbilical cord is typically compressed during this time. So it's important to get that resolved as quickly as possible. The key is, although it's often said that shoulder dystocia is not preventable or predictable, um, there are a number of risk factors. We were talking about what constitutes high risk pregnancy. There are a number of risk factors that place a woman at higher risk for having a shoulder dystocia. That doesn't mean for every obese woman we do a C-section to avoid shoulder dystocia. It doesn't mean for every diabetic woman we do a C-section or everyone would be having
Yeah.
C-sections.
Right.
There's already enough,
And the
right?
C-section rate is
Already
already
is it?
25,
It's
30%.
crazy.
So, but this is kind of where the art of medicine, I think, is important to recognize what the risk factors are. So if a woman's diabetic and her baby is, and we talked about ultrasound to monitor the baby's growth. If the baby's weight is above a certain threshold, there are guidelines, whether the mother's diabetic or not diabetic, to do a C-section, depending upon how high the estimated weight is of the baby. Women that have very prolonged labors, that potentially is another risk issue that's associated with shoulder dystocia in some literature, but not all literature. But if you have a woman who's diabetic, her baby's fairly large, maybe it doesn't meet the criteria to do an outright C-section, and then she's having a very prolonged abnormal labor, that could be the writing on the wall to alert somebody that's attending to a woman in labor, say, maybe this vaginal route should be detoured. So there's a lot that goes into that, and but yeah, it's
I'm stressed even just hearing
Yeah.
about this. It's really
Well,
incredible what OBGYNs do.
it's I think if you talk to any obstetrician or midwife, they'll tell you that it is, and it's been described this way, as one of the most feared, if not the most feared, obstetrical
100%.
complication, because you're typically dealing with a full-term baby that's about to be born, mother's been in labor, and
Got a husband there, maybe a mom there. It's a
sure,
lot.
families there, everything,
Big performance.
and head comes out, and rest of the baby's not
Yeah.
coming. And then it's most labor and delivery units will actually call a specific code when they encounter a shoulder dystocia, so that all
Everyone's there.
kinds of help
Yeah.
comes in to help resolve the shoulder dystocia.
Another, this is kind of personal for me, but another thing that I want to ask you whenever we have a doctor in the chair, I'm like, sorry, I just want to talk about my past traumas that I've had. But during my C-section with my son, and again, I was 34 weeks, a couple days, and C-section, obviously, because of the vasa previa, but I had a focal accreta. And it was able to be resolved without you're smiling.
Boy,
I know
you're
I've
like
had a lot. Oh,
like a textbook.
Yes.
you know what?
She
I could
really
stay
is.
down here, and I haven't even gotten to my second birth, which I will spare you
You're more
from.
than one chapter now.
I am
We're
a
going
few.
to the next chapter.
Yeah. Okay. So a focal accreta, and
Okay.
I think I was, my son was born 34 weeks, so my biggest worry was okay. The vasa, what do you call it? The vessel was like about this big. I have a picture. I'll show you later. It was
Yeah.
huge. It was the biggest one Hoag Hospital had seen, not to hit any records or anything. And I was most worried about my son and my son going to NICU and my husband being with him. But then after the C-section, I'm like, okay, this is my first one, but like things are really taking a long time. And there's like a lot of pressure, and there was just a lot happening that I was like, this doesn't feel very normal. And my doctor at the time would say, you're okay. You're okay. But she was sitting there and she was holding I guess, the uterus
Yeah.
because
yeah.
I had a focal, and she didn't want to, she knew it was my first baby.
Didn't want to do a hysterectomy.
She didn't
if
want to
she
take
could
my
avoid
uterus.
it. Yeah.
Yeah. So she was an angel, and she sat there holding the bleed until it stopped. And this is why, like, I get chills just talking about it. But I'm like, I could have had a surrogate. I had extra embryos, like all that. But like, being able to carry your baby and like the trauma of that. Yeah, not only is your baby out, but like, oh, by the way, you also have a hysterectomy and you lost your uterus. Why are we seeing so many of these? And how did my doctor or the techs not see it in an ultrasound? Like, she didn't know until she was in there that my placenta was not detaching from my uterus and there was a small focal. I know
Well,
I probably said so much without saying a lot, and also like very confusing because I'm not a doctor, even though I think I'm a TikTok doctor sometimes in my experience. But
sure. If anything is tied with shoulder dystocia for imparting fear into the obstetrician or whoever it might be that's attending to that delivery, it's placenta accreta,
Yeah.
undoubtedly. So placenta accreta, focal accreta, and it makes me wonder if you had a previa at some earlier point in that pregnancy that resolved, because if you have a previa, there's a significant risk of accreta.
of a placenta previa.
Yep.
and then the more risk of an accreta, and then more of a placenta accreta. So I was just like a bam, bam, bam.
Right.
Okay.
Exactly. So you may have had a previa that resolved enough and led to the vasoprevia, which we know is an association. And then at the time of delivery, because you had the previa, perhaps there was this element of accreta that developed as well, because this is something that many people don't know, that even in the absence of a previous cesarean section, which is the highest risk factor for accreta developing,
Mm.
even in the absence of that, if you have a placenta previa with no previous C-sections, there's a significantly increased risk for accreta. And accreta is simply the situation where the placenta invades more deeply into the area of attachment within the uterus. Typically, the placenta attaches just enough so we can have the normal exchange of oxygen and waste products between baby and mother through the circulations, through that interface with the placenta. Baby's born, wait a minute or two, little massage of the uterus, and out comes the placenta. In the setting of accreta, or invasive placentation, as it's called, um, the placenta invades deeper than the normal attachment. And so when the doctor goes to deliver the placenta, it's not coming, or in a focal accreta, part of it's not coming. And the risk is that any attempts to disattach that
Bleed out.
lead to severe hemorrhage risk.
Yeah.
Severe hemorrhage risk, torrential hemorrhage risk. So prenatal, before delivery diagnosis is critical. So first, the identification of women at risk, previous C-sections, other uterine surgeries that may have taken place outside of pregnancy, predisposed to accreta, including D&C,
Mm.
and then ultrasound and other imaging, such as MRI, are utilized as adjuncts to making the diagnosis. But there can be a placenta accreta even in the absence of risk factors and even with normal imaging.
Yeah.
But one utilizes all of those things to develop a relative risk or a likelihood. And when we think the likelihood is high enough, then specific protocols have to be put into place.
Well, this is why I feel like you have to be at a really good hospital.
Right.
Because with my second, and I'm curious because Taylor and I both had VBACs, and you being an MFM, I'm curious your thoughts on a VBAC. But with my second, I had a VBAC and then I hemorrhaged and lost 4 liters of blood. So that was, but I did a successful VBAC.
That's almost your entire blood volume, by the way.
Yeah, it was
Yeah.
why I was in a surgery for 2.5 hours. It was crazy. It was a
Okay.
lot.
You are a complete
Yes,
textbook.
I am a
Yes.
textbook. I know I've had, and I want more. Do you think I could have another one?
Our OB said, "Ooh, why don't you just take a break?"
I know. I would love one more because I have embryos.
You can, but whether you should, that's a personal decision, right?
Gosh.
I know.
Thank God my husband doesn't listen to my podcast.
VBACs are definitely a legitimate component of pregnancy care in terms of delivery options for someone who's had a previous C-section. But there are clearly, risks involved.
Yeah.
But there's risk with cesarean section as well. And I think it's something maybe we didn't touch on is just how important individualized care is.
Totally.
We kind of live in this world now in medicine of algorithms where, you go on the internet or AI or whatever one's using as sources of information, and there's typically an algorithm for, and that's great, but they don't always include the nuances of a particular patient's circumstances.
Yeah.
And that's something that I try to teach the
So
the
don't go to
residents.
ChatGPT for your OBGYN needs. You need the human aspect.
You
and
need the
it's
human aspect.
individualized.
I'm not putting down any of that, though, because there's great information
Sure.
available there. And this is what I teach the residents and the fellows that are training where I work, is that, to be the best, you really don't have to memorize a whole lot anymore.
Yeah, which is wild.
You got to care an awful lot.
Mm-hmm.
you have to pay a lot of attention to all the details. Don't put things off. Don't wait for the lab result to come in, and not check it until a couple days later when
Oh,
you gotta, be really compulsive about these things,
that is
and
very
you
good
have to know where
advice
to find information.
because the
Um,
information's out there. I mean,
Information's out there, but caring is just such an important part of it, and communicating the information and understanding that not everyone fits an algorithm. But again, algorithms are important, but there's sometimes room through what we call shared decision making to go in one direction versus the other.
right.
And shared decision making is just kind of a buzz phrase, really, for involving the woman in her own health decisions,
Yeah.
which is
What a concept, huh?
uh, critical,
Yeah.
and something that respects the autonomy from an ethical standpoint of our patients.
I think what I'm thinking of right now is personally, like if I'm 36 years old, two very complicated IVF births and pregnancies, really. But for all women, why wouldn't any woman just go to an MFM? Like I can't imagine, and I love my OBGYN. I made her switch to him. Like I love him. I've made everybody I know switch to him. However, I'm also like, there's so much on the line. How could you not have both of that care? Is it an
Well,
insurance thing?
I think no, I don't think so. I think first of all, maternal fetal medicine specialists have different practice models. Most maternal fetal medicine doctors are consultative. In other words, the patient is referred from
Right.
a midwifery practice or an
OB.
OB, general OB
Yes.
practice. They say, oh, you have gestational diabetes. We've done the third trimester testing. We're going to send you to the maternal fetal medicine doctor to talk to you about that, to put a care plan in place based on this new diagnosis. The maternal fetal medicine doctor does that, might plan to see the patient back once or twice, but the ongoing care is
Is with
with
the OB.
where
See,
they
I think I
came
just
from.
like all the attention. I'm like, I just want all
I
the
know, it
I need
is
all the
nice, and
boxes
the
checked.
attention to detail. Well, I was gonna say, I feel like we could talk to you for hours about, like,
Yeah,
going through every single thing. Obviously, we don't have that time, but there's one thing that I do wanna touch on before we close, and it's the
sure.
preconception care that could possibly lower the risk of birth defects. And is that taking supplements? Is that living a certain lifestyle? Is that nutrition? Like, what does that look like for women?
It's great because to talk about this because truly pregnancy care begins before pregnancy.
Mhm.
Seems like an oxymoron,
Yeah.
right? How can there be pregnancy care before there's a pregnancy? But to have the healthiest pregnancy, seeing a primary care doctor or an OB, preferably, to talk about one's health history, one's medication history, one's circumstances with past obstetric complications or not, helps devise a medical strategy to optimize a woman's health before conception. So, just to throw some specifics out there, in terms of reducing birth defects, obesity increases the risk of birth defects. Diabetes, poorly controlled, increases the risk of birth defects. A lack of folic acid preconceptionally and through the early weeks of pregnancy increases the risk of specific birth defects that are either lethal or severely debilitating. Anencephaly, the lack of development of the skull and the brain, and abnormal development of the spine, of the spinal column and the spinal cord. Folic acid, since the 1990s, has been recommended to all women capable of pregnancy. So, what does that mean? Within a age range where pregnancy is possible, and even in the setting of contraception, which is not 100% effective, it makes sense to take advantage of this recommendation because many pregnancies are unplanned, probably half, and that involves consuming folic acid 400 micrograms per day which is typically what you'll find in
Prenatal.
you'll probably see more than that in a prenatal
Okay.
vitamin.
So I want to ask about this because I went down a rabbit hole because I have MTHFR, both gene
We
mutations.
can talk about that.
I would love to talk about
You
this.
have
I
two
have two gene mutations of it. So my dad
of
and
the
my mom.
same one of
It's a
this.
different one. I don't know. I think I have both ones when I did my
Okay.
gene test.
Okay. Okay.
So, and I found this out with my before my second pregnancy. So instead of folic acid, because I've realized that my body can't break down folic acid, I take folate.
You should take the recommendation is folic acid.
But isn't that already broken down from folate? Isn't folate the pure form
No,
or no?
folic acid is what's been shown to reduce the risk of birth defects.
Okay.
Folate is kind of a more generic term as it relates to what one may find in foodstuffs, for example, leafy greens
Mhm.
and peanuts and other things
Avocados, yeah.
that are rich in folic acid. It's
Okay.
rich in folates, but absorption varies from individual to individual. And so the recommendation is not necessarily to eat foods that are rich in folates. That's a healthy way of eating, no
Sure.
doubt. But to prevent birth defects of the spine and the brain, folic acid is what's recommended, either in the form of fortified foods where you're getting 100%, like there's some fortified breakfast cereals that have 100% of the folic acid that's necessary, or a multiple vitamin, as long as it says 400 micrograms or zero point 0.4 milligrams. It's different for a woman who's previously had a child with one of these birth defects, then it has to go to 4 milligrams or 4,000 micrograms. But obviously, someone like that should be seeing their doctor beforehand.
Yeah.
I had a
Right.
baby with spina bifida. I'd like to have another child. What can I do to reduce the risk of that happening again? But it's been shown that we can reduce significantly the number of babies that are born with spina bifida and anencephaly, and there's another one called encephalocele. Probably can reduce by 700 the number of babies that are born each year with those birth defects if everybody was aware and taking advantage of a very
Supplement.
simple way of preventing birth defects, and that's
Yeah.
just a simple B vitamin, folic acid.
Wow.
Wow. That's incredible.
As far as obesity and the risk of birth defects, all birth defects are higher in women that are with BMIs above 30 than under 30 that are of ideal body weight. So optimizing one's weight prior to conception would be a way that one could change a modifiable risk factor for birth defects. And as we touched on earlier, as it relates to diabetes and birth defects, making sure that the hemoglobin A1C, which is anyone with diabetes out there has
Knows,
heard
yeah.
that term, that is the blood test we want to see in the normal range
Before
before
conception.
conception
Yeah.
to make sure that the risk for birth defects is not higher than what the baseline risk might be.
Well, and I know that we've sat there through anatomy scans, and I feel like all moms have, and you're just sitting there holding your breath of like hoping
Mhm.
and praying, but like knowing this of like before you even think about conception, you have to be taking these.
E-
All women.
Exactly. Pregnancy care begins before pregnancy.
Yeah.
I think that's some of the
It's huge.
best advice that we can end on, because so many women, and we had an IVF doctor in before, and then we've had our OB on, and it's like you go to the doctor when you want, like when you peed on your stick and you find out you're pregnant, and it's so important to go before and to talk about what your overall health looks like, because I think even for me, like, and most women in general, like, I didn't see a
Yeah.
regular doctor before my OB. The only reason I'd go to the doctor now is because I was pregnant. At anytime I'm writing down my primary care, I'm like, Dr. Ellick, my OB/GYN, because
I'll
we don't
just,
care enough.
yeah, I would just add as it relates to the folic acid, the reason that recommendation is in place to be consuming the folic acid at all times, not just at the first prenatal visit when you get the vitamins and such, is because the neural tube, which when it doesn't develop correctly and develops these birth defects because of that, is completely formed by 28 days
Crazy.
after conception.
Wow.
Way before you go
So
to the doctor.
right. So by the time you
It's
get
too
to the
late.
doctor, even if you're the most compliant person and really, I'm going to do everything and get to the doctor early first trimester care, it's already a done deal.
Wow.
So one has to be taking in that folic acid prior to conception so that when the baby is conceived and those earliest weeks of development are the most critical.
So you're saying like even right now we should be, because we are of the age,
Yeah,
right, that we should be taking this in every
that's
day.
that's I mean pretty much all the health organizations, CDC and others, have that standard recommendation. And
Wow.
for the reason of avoiding and having delivered many children with anencephaly, and spina bifida and encephalocele. And these are as I said, anencephaly is lethal. Spina bifida is oftentimes requiring wheelchair, incontinence of bowel and bladder, complications of too much fluid in the brain. When this is diagnosed, though, in utero on that anatomy ultrasound, if it shows up, we were talking about various surgeries that can be done. This is one that has proven effective over the course of time, where there are specific fetal surgeons around the country in very specialized centers that are repairing spina bifida of the fetus
Wow.
before delivery. And those babies who have that treatment in utero are showing improvements in terms of their outcome, in terms of their motor function, and other measures of good outcome compared to those that are carried through the pregnancy, delivered, and then treated surgically after
Later. Yeah.
delivery.
It
That's
must be
incredible.
so incredible for you to see all of these advancements in
Amazing.
medicine.
Yeah, you've seen it all, huh?
Yeah,
And there's more to come.
I know.
Yeah.
Many more-
Faster probably now than ever before.
Yeah, it's amazing.
There's more to come for
Yeah.
sure.
Oh my God. Well, thank you so much for being here
Yeah.
Been a
and sharing
pleasure.
all of this. So, like,
It's
I could
amazing.
just have
I
you
know.
keep coming on and talking
Great.
to us about more things. So thank you for being with us today.
Absolutely, my pleasure.
And will you tell everyone where they can find you as well? Your practice is called?
I'm in Phoenix, Arizona. I've been at the same hospital for 33 years.
Amazing.
The last couple of years, primarily office based now. And I'm at Banner University Medical Center, which is on McDowell Road in Phoenix. And I have an easy email too, dr as in doctor, drperlow@gmail.com.
Amazing.
I
We're
love
so
that.
grateful for you coming all this way and
A
sharing
pleasure.
all of your knowledge and hearing all of our stories, giving us a little therapy too.
Absolutely.
Thank you,
Anytime.
Dr. Perlow.
Anytime.
Thank you.